Your textbook highlights a number of different conditions, generally genetic conditions, that are caused by abnormal development of the skin and musculoskeletal system. I've provided some references in the Canvas module for you to look at to give you a sort of a more detailed picture of some of these diseases, but I wanted to highlight a couple of them, in part because they're really great examples of embryology gone wrong, and also because they're the kinds of conditions that you may see in a clinic in your future career, and it's worth knowing a little bit about them and what they mean for families. So the first one we'll talk about is epidermolysis bullosa. We're going to focus on the dystrophic type. There are many different types. They are inherited in different ways. This particular type is autosomal recessive and caused by mutations in the COL7A1 gene on chromosome 3. This condition can actually be quite variable, although what you'll see from the resources I've provided is that certainly in its severe case, it is very severe. And in fact, the tagline for the support organization for dystrophic epidermolysis bullosa, which is called DEBRA, DEBRA, their tagline is, "This is the worst disease you've never heard of." It is rare. Most people have not heard of it, but it is also really, really awful. In this case, what you have are kids with extremely fragile skin. In some cases, they're referred to as butterfly children because you touch their skin and it just comes right off. So it's very, very fragile. They form blisters with minimal contact. These are babies you can't hold, you can't snuggle, because you'll hurt them. It's very, very painful, as you would expect it to be if your skin was constantly being sort of separated and pulled off of your body. They get a lot of scarring, which can affect how they grow, and they can get this blistering not only on the surface of their skin, but also on the lining of some of their internal processes. So it makes it difficult to eat, to swallow, to breathe. The scarring can also affect function because as the skin heals, it can actually sort of seal up in ways that it shouldn't. So it can seal fingers together or lock them into position. Same with the toes. It can sort of constrict the opening of the mouth and the nose. And these folks are very, very prone to skin cancers because all the frequent damage and repair of the skin leads to very frequent, essentially, turnover of the cells. And the more cells you're turning over, the more times you're copying your DNA, the more likely you are to make an error and the more likely you are to get a cancer. So the risk for skin cancer actually becomes very, very high for these individuals if they live into adulthood. Why does this happen? So in this case, the COL2A gene makes this protein that assembles the type 7 collagen. So we talked about how collagens are responsible for helping to hold the different layers of the skin together, and this one is no different. Type 7 collagen is critical for holding the epidermis and helping it adhere to the dermis. So for folks with EB, what's happening is their epidermis is separating from their dermis because there's nothing to hold it together. So even very, very minor traumas, things we wouldn't think of as traumas, cause that separation and they develop blisters. But unlike blisters that you or I might have where the fluid can accumulate and provided you leave it alone will then be reabsorbed by your body, they continue to grow and grow and grow. And so for folks that have EB, part of the treatment is to actually lance the blisters to allow that fluid to escape, which allows them then to heal. How do you manage this? How do you treat it? There is no cure for it. There's some interesting research currently going on, but no cure. At the moment, all of the treatment or management is symptomatic. Managing wound care, which if you look at the resources I provided, you'll see it's an extensive process. It takes hours, several days a week, if not every day of the week, and it's very painful. Pain management generally with medications. I didn't put it on here, but a lot of times these folks end up with G-tubes, which is essentially a button that's sort of built into the abdomen around the area of the stomach to allow you to be tube fed, so nutrition sent directly into the stomach. That's critical if it's too painful for you to eat. And of course, screening for skin cancers is critical. Next up, I thought we'd talk about X-linked hypohidrotic ectodermal dysplasia. I highlighted this one because I've actually seen folks with this several times in the course of my 12 years of working in prenatal genetics. It seems to come up more often than I might think it would. And for all that it does not generally affect intelligence or physical function most of the time, it still can be very severe and can have a huge impact on how people live. So, this one, I'm focusing on the X-linked form. There are many different forms inherited in many different ways and lots of different genes associated with them. This is just the X-linked form because I think the X-linked form is kind of interesting and it's the one I've run across. In this case, the gene is EDA, again on the X chromosome. As you might expect, males are much more severely affected than females. In the picture here, this is a little boy who has this condition and his mother. And what's interesting is that your book will tell you that this is X-linked recessive. I think that's how your book is describing it. I would argue that it's really just X-linked. Many, many women who should be carriers of this condition, please hear the air quotes there, many, many women who should be carriers are in fact symptomatic, just much more mildly so than the males. So it's really hard to say it's recessive when the carriers have symptoms. At any rate, I'll get off my soapbox. But in general, the males are much more severely affected than the females, although in rare cases, women are in fact as severely affected as the men. Now, one of the primary features of this, and the hypohidrotic component there of the name, is that these folks have reduced or abnormal sweat glands, and that dramatically reduces their ability to sweat. And this can be lethal, particularly for young infants that really can't tell you how they're feeling. These are kids that overheat in a heartbeat. Sweating is critical to your regulation of your temperature. If you can't do it, you can overheat to critical levels very, very fast. And in several of the families that I've seen with this condition, it was diagnosed after a baby died, seemingly in a safe situation, well dressed, well cared for, but died, and likely due to hyperthermia. These folks also have hypotrichosis, which is reduced hair. Their hair tends to be lighter in color. It tends to be very sparse, very fine. Hypodontia, so underdeveloped teeth, fewer teeth, abnormal teeth. You can see some of the teeth here. They tend to be very conical in their shape. And there's a lot of variation in terms of how many these folks have. Sometimes for women that are very mildly affected, the only symptom may be the teeth or the hair. They have dysmorphic facial features. Their foreheads tend to be prominent. Their lips tend to be a little bit thicker. They've got this flattening at the bridge of their nose. And it just sort of all generally comes together to give them a particular look that tends to go along with this condition. There are some skin findings as well. They tend to have very dry skin. They can have eczema. But one of the interesting things about this is because it doesn't generally affect intelligence, a lot of times this gets assumed to be a cosmetic issue, when in reality there's a little bit more to it than that. So, how does this happen? Well, the EDA gene makes this ectodysplasm A protein, which is critical for the interaction of the embryonic ectoderm and mesoderm. So we talked a lot about how most body structures are derived from a combination of those three primary tissue types. Well, if the two of them can't talk to each other, you're not going to get normal development. Additionally, the EDA gene makes a couple different isoforms of this ectodysplasm protein, and one of them is involved in ectodermal signaling in a pathway that's critical for the formation of hair follicles, sweat glands, and teeth, which makes a lot of sense for a condition that affects hair follicles, sweat glands, and teeth. In terms of management and treatment, no cure, okay? This is not something that we can fix, but there's certainly some recommendations for management. First and foremost, temperature regulation is critical. So these are babies that you underdress, and you sort of keep a very close eye on until they're old enough to tell you when they're overheating. And then just sort of basic common sense kinds of things. Always carry water, sit in the shade, don't plan to spend an entire day out in the sun. The kinds of things that it's easy to say, but sometimes hard to incorporate into a lifestyle until you've really lived it. In terms of some of the issues that occasionally get considered cosmetic and really aren't, these kids get dental prostheses and as adults dental implants. Many of the children that have this condition really don't have enough teeth to eat normally. And for those that can't, nutritional assistance is important. There are lotions and creams for some of the skin manifestations, and wigs can be very helpful in terms of good self-image, body image, self-confidence. These are folks who do look different, and in ways that society does not often consider attractive. And that can be a real challenge, a real challenge. And so some of care and treatment for this is really about helping folks to feel like they're fitting in and like they're not as different as they sometimes think they are. Okay. Next up, achondroplasia, one of my personal favorites, and a great example of an embryologic bone growth issue. So this is dominant, although again, many cases are de novo, meaning that they arrive from a sporadic mutation in an egg or a sperm, although often a sperm. So we did spend some time talking about how a woman's age affects a pregnancy, but a man's age can affect it too, but differently than a woman. So by way of refresher, women's age affects the process of meiosis in their eggs. But a man's age, pardon me, not eggs, men don't have eggs, but a man's age affects the number of times that the DNA within the sperm has been copied. So remember back to your gametogenesis lectures, the formation of sperm continues over the course of a man's lifetime. So over the course of a man's lifetime, those sort of primordial sperm cells have been replicating themselves thousands, if not millions of times, and they start to accumulate errors. So older fathers are more likely to have children that have sort of random genetic errors, typos. There's no, at this point, as best we know, no particular reason to think they're localized to one region of the DNA or another. But as a result, de novo mutations are more common in children of older fathers. It was a little bit long-winded, but there we go. So at any rate, for achondroplasia, certainly it can be inherited, it can run in families, but a lot of times it's new in that particular child. It's caused by mutations in FGFR3 and chromosome 4, and it displays clinical heterogeneity. And by that, what we mean is that this gene, this one gene, can actually cause any number of distinct and separate genetic conditions. So achondroplasia, sure, but also hypochondroplasia, which is kind of like achondroplasia but milder, sedan dysplasia, which is more severe, thanatophoric dysplasia, which is lethal, all caused by mutations in the same gene. Also interesting from a genetic perspective, so as I'm sure you guys know, if it's dominant, then if a person has achondroplasia, there's a 50-50 shot that each of their children will. But as is shown in this picture here, we've got a couple where both the husband and wife have achondroplasia. They have 3 children who all have it as well. But if you inherit a double dose, the double dominant, so if you inherit the mutation from both parents and have no normal copies of FGFR3, that's actually lethal. So one of the counseling issues for families where you're dealing with both parents, both prospective parents with achondroplasia, is that roughly 1 out of every 4 pregnancies will get the double dominant, both mutations, and that is lethal. Okay, and if you're curious, this family here is actually featured on a show on TLC called Our Little Family. I'm not sure if it's still on or if it's just in reruns, but TLC certainly does seem to have a great interest in featuring people with various types of dwarfism. Okay, so achondroplasia, one of the most common forms of dwarfism. It's, of course, causes short stature. Men generally reach a height of, on average, 4'4", and women 4'1". What you get is this sort of shortening of the limbs, and in particular the upper long bones of the arms and legs, with relatively normal trunk size and head size. In fact, the head may be a little bit large, and you get what's called frontal bossing, which is a little bit of a protrusion of the forehead. A lot of times folks that have this developed curvature of their spine, they aren't necessarily born with it, but because of the abnormal limb length, they sort of end up developing it over time. Likewise with obesity, they're more likely to be obese, although not directly a function of the syndrome, a secondary effect of the skeletal changes. Sleep apnea, spinal stenosis. So spinal stenosis, the hole at the base of the skull where the spine sort of goes up and into the skull a little bit, that can be narrower. And if it is, you can end up with sort of a pinching in that region, which can be life-threatening. Most folks with achondroplasia won't have it, but it's something you have to be monitored for. And again, a relatively rare complication, hydrocephalus or fluid accumulating in the brain. But most folks with achondroplasia will lead relatively healthy lives. So FGFR3, what is it? It makes a fibroblast growth factor receptor, the third one in particular. But mutations in this gene inhibit the chondrocytes at the growth plates. So they make it more difficult for the chondrocytes to lay down cartilage, and if you can't lay down cartilage, then you're not going to form bone because that bone forms via endochondral ossification, which requires a cartilage template. And so what you get is this sort of shortening of the long bones because of this error in bone formation. How do you manage it or treat it? Well, certainly you need to monitor for signs of spinal stenosis or hydrocephalus. Those are potentially life-threatening, if somewhat rare, complications. Some folks are going to need some orthopedic help. They may get bowing of the legs that requires management. Curvature of the spine might require some management. But in reality, a lot of folks with achondroplasia are really pretty healthy. And if anybody watched last night, or depending on when you're listening to this, last week, Peter Dinklage, star of Game of Thrones, has achondroplasia. It's certainly not something that has to be life-limiting or has to be life-restricting. It can be a very long and fulfilling life, and it's sometimes nice when looking at all these genetic conditions that don't always make it possible to lead long and fulfilling lives, to look at one that doesn't necessarily interfere with that. Now, again, there are some additional resources on the course website to explore these conditions in more detail. If you have any questions, I'm certainly happy to answer as many as I can. Feel free to send me a message.